Let's just jump right into this explainer. Today, we're unlocking the absolute ultimate blueprint for mastering what is arguably the most common neurology case you're going to face in the MRCP PACES exam. Yep, we're talking about peripheral neuropathy. I absolutely love starting with this examiner's note because it shows you exactly what's on the line here. Look, we're not just trying to scrape by with a minimum score, right? We are aiming for absolute excellence. Taking a basic diagnosis of peripheral neuropathy and transforming it from a standard pass into a clear pass takes a really specific, targeted approach. So here's our roadmap for the encounter. We'll start with the clear pass mindset, move on to those crucial first impressions, then map the neuropathy, face the examiner, and finally wrap up with investigations and management. Okay, section 1, the clear pass mindset, where specificity is absolutely key. Specificity really is your golden ticket here. Think about it. If you walk up to that examiner and just say, peripheral neuropathy, you've instantly hit a scoring ceiling. There's nowhere else to go. But if you confidently declare the exact pattern of loss, saying something like, I found a sensory motor large fiber neuropathy with the following differentials, boom, you've instantly proven you know exactly what you're doing. Moving right along to section 2, crucial first impressions. And this is all about what happens before you even touch the patient. You know, it's wild how much background info you can gather just by observing, almost like a detective. Check out their shoes for ankle supports or scuffs on the front, because that basically screams foot drop. Do they have slip-on shoes or maybe a shirt missing some buttons? You're already picking up on a loss of manual dexterity. And don't forget to quickly scan the skin and joints. Dryness, ulcers, or Charcot deformities are huge red flags, warning you about severe pain and proprioception loss. Now, before you even reach for your tendon hammer, you've got to palpate the peripheral nerves. Honestly, checking the common peroneal at the knee, the ulnar at the elbow, and the superficial peroneal nerve in the foot is a massive shortcut. If they feel thickened, your differential diagnosis immediately narrows down to 4 high-yield suspects: amyloidosis, hereditary motor and sensory neuropathies, leprosy, or acromegaly. All right, section 3. Let's map the neuropathy by looking at the pathophysiology and patterns. So, the most common form of axonal degeneration is called the dying back phenomenon. And because it's completely length dependent, the absolute longest nerve fibers in the body are the ones affected first. That means the weakness always starts down in the toes. But as it ascends up to the knees, something really fascinating happens. The distal fingertips finally get involved, and that's exactly what creates that classic stocking and glove pattern we always hear about. Now, small fiber neuropathy is just such an elegant concept to grasp. It impairs the small caliber sensory nerve fibers. We're talking the thinly myelinated A delta fibers responsible for cold and pain, and the unmyelinated C fibers for warmth. But here's the kicker. Because the large sensory afferents coming from the muscle spindles are completely spared, the patient's tendon reflexes remain perfectly intact. Examiners absolutely love testing to see if you actually understand why that happens. Let's look at this table to keep things straight, because under pressure, differentiating these sensory loss patterns comes down to clear contrasts. If vibration and proprioception are totally gone, but the patient feels pain and temperature perfectly fine, that's a large fiber neuropathy. On the flip side, if pain and temperature are lost and you're seeing autonomic issues like pale, really cold limbs, but they can still feel vibration, you're definitely looking at a small fiber neuropathy. Memorize this contrast and you won't get tripped up. And when you actually ask the patient to walk, pay close attention because their visual compensation tells a massive story. A high steppage gait, that's a clear indicator of foot drop or loss of joint position. What about a wide-based gait where they're intensely staring at the ground? They're visually compensating for sensory loss. And that leads directly to a positive Romberg's test. The second they close their eyes, you remove that vital visual input and they become incredibly unsteady. Which brings us to the climax of the encounter, section 4, facing the examiner, or as we like to call it, the interrogation. You are almost certainly going to hear this exact question, Doctor, what are the common causes of a sensory motor polyneuropathy? So how exactly should we structure our answer? To really prove your differential diagnosis is rock solid, you want to group your answers logically. Don't just rattle off a random list. Start with the metabolic causes, so alcohol and diabetes, maybe hypothyroidism and uremia. Then, smoothly pivot to systemic causes, like sarcoidosis and vasculitis. Finally, cover the demyelinating and genetic ones, like Guillain-Barré and hereditary neuropathies. That kind of structure projects total confidence, and it completely allays any fears the examiner might have about your clinical reasoning. Next up, they will inevitably try to trip you up with pharmacology. It literally strikes dread into every candidate's heart. They'll ask, and what specific drugs can cause this neuropathy? But don't panic. If you categorize the offending drugs by the exact type of neuropathy they cause, you'll sound incredibly composed. For a purely sensory neuropathy, cite isoniazid, metronidazole, or colchicine. If it's motor, dapsone is your go-to answer. And for sensory motor, think about heavy hitters like amiodarone or chemotherapy agents like vincristine and cisplatin. Grouping them like this shows true mastery of the topic. Finally, they might decide to throw a curveball at you regarding an asymmetrical presentation, asking, what are the causes of mononeuritis multiplex? Now remember, mononeuritis multiplex is simply the asymmetric involvement of multiple individual nerve trunks. Again, group your answers. Start with diabetes, then move into the vasculitis like polyarteritis nodosa or Wegener's. Follow that up with connective tissue diseases like rheumatoid arthritis and SLE. Throw in sarcoidosis and amyloidosis, and round it out with infections like Lyme disease and leprosy. Structured thinking proves you're a safe, thorough doctor. Okay, the home stretch. Section 5, Investigations and Management, completing the picture. Presenting your investigations in a tiered format demonstrates that you actually know how to work up a patient on the ward. Start with the basic bloods: fasting glucose, HbA1c, B12, serum protein electrophoresis, and autoantibodies. Check the urine for glucose and Vence-Jones proteins. Only then do you explain that you'd escalate to specialized stuff like nerve conduction studies, CSF analysis, genetics, or a nerve biopsy. And when you wrap up your presentation, always emphasize a multidisciplinary or MDT approach. Proving that you treat the whole patient and not just the nerve lesion is absolutely crucial. Mention patient education. Bring in physio and occupational therapy to maximize their function. Talk about analgesia for that burning neuropathic pain. And of course, providing orthotics and walking aids to keep them mobile. So you've mapped the nerves, you've survived the interrogation. But before you walk out, look the examiner right in the eye and say, I would like to take a complete drug history. Saying this proves you understand that our very own treatments can often cause these neuropathies. Master this, and that clear pass is totally yours. But honestly, it does leave us with a pretty startling question for next time. Just how many other mysterious neurological symptoms are hiding in plain sight, right there inside your patient's pillbox?